Good morning, everyone. This is our first official Friday grand rounds of the season. Thanks to everyone for coming to observe this morning. We've got Dr. Derzi, who's here to present alongside some of the faculty from the undergraduate curriculum about some new exciting changes to anesthesia module, which has started within the last couple of months. So we're going to hear
Weeks.
Couple of weeks, yeah, which we're going to hear about. So someone's going to give us a presentation, and then there'll be some other faculty from the medical school to answer any questions for us. And hopefully all our tech gremlins have disappeared and we're presenting online, and so good.
Okay,
Thanks.
thank you. Okay, so good morning. So today we're going to be talking about the Med 556 clerkship. I hope we can answer to all the questions you guys have, and hopefully we decrease the amount of emails that we have been sending over the last weeks. I'm just part of the team. We invited the whole team here. So in person, we have Dr. Rolfson. I just would like to introduce everyone. So he is the Associate Dean of the MD program at the University of Alberta. And he is a geriatrician and educator who provides leadership for the MD program. We have, I believe, online, we have Dr. Lena Bistritz. She's our Assistant Dean of Curriculum at the University of Alberta. She oversees the development, delivery, and evaluation of the MD curriculum, ensuring it meets accreditation requirements. We also have, hopefully online, Dr. Lee. She's the director of the undergrad med education program and clerkship coordinator for Med 546 and Med 556. We have here in person, thanks so much for coming, Kelly Gibson. She is our program evaluation specialist in the Faculty of Medicine. She brings expertise in evaluation, learner assessment, and educational quality improvement, making sure clerkships like the Med 556 are assessed for effectiveness and long-term impact. Online, we have our Dr. Vince Lau. He's our intensivist and the lead for the critical care portion of the clerkship. I'm Simone Derzi. I'm responsible for the anesthesia side. We have Dr. Sunny Fong. He's our former anesthesia resident and now critical care fellow. He has contributed greatly given his background in both anesthesia and ICU. And finally, but not least, we have here in person Olivia Case. She's our program assistant who has been amazing in managing all the administrative aspects of this clerkship. So this clerkship was just launched just a few weeks ago, and it started in August and will be going until April. So this is going to be our academic year. We are going to cover the structure of the clerkship, the EPAs, clinical encounters, how the AHD is going to work. We're going to explain a little bit about the faculty appointment requirements, how the compensation works. We're going to talk about student feedback on clerkship and a little bit about our future, including the simulation that we would like to start next year. So a little bit of history. I've heard, I was not here, but I've heard that around 10, 12 years ago, we had some structured exposure to anesthesia. It's nice to have this conversation at the end of the presentation because a few of you were here at that point. But what I've heard is that the med students were not very enthusiastic about anesthesia at that point. And so the staff felt that a little bit discouraged, and this structure exposure disappeared over time. The reality today is a little bit different. Anesthesia has been more popular. The students want to have more exposure to the specialty. So they are expressing interest in having a structured clerkship. So over the years, the University of Alberta med students graduated without this core rotation in anesthesia and critical care. But now we are trying to change. So here you can see a list of universities that still do not have this core rotation. We already have an X marked there, so we are starting now, but we still have a few that do not have the same. So what has happened over the last year? So just to let you know that things did not start this month or last month. So everything kind of started in 2022. People were talking about, can we bring anesthesia / ICU back to the curriculum? In February 2024, there was an MD program curriculum retreat, and the mandatory rotation in anesthesia critical care was highlighted as a major gap. And the students indicated there and have been indicating that more exposure to anesthesia and critical care would be beneficial to their training. So in the same year, in October, the MD Curriculum and Program Committee, MDCPC, approved this clerkship as a pilot to be started this year, and we started in August. So how does it work? We have critical care and anesthesia under the umbrella of internal medicine. So the rotation is 4 weeks. We have 4 weeks of rotation, but it's divided 2 weeks in internal medicine and 2 weeks in critical care or anesthesia. And during their time with us, they need to do 4 EPAs, 3 clinical encounters, and they need to attend 1 academic half day. We are going to be talking about each of these items very shortly. We developed the curriculum, and every curriculum we have objectives. So these objectives are to be met by all the med students, either if they are assigned either to anesthesia or critical care medicine. So we would like to have the students to take a focused history and targeted physical examination. It's important to say that if they are in ICU, the med students are expected to round or help with 1 patient a day, at least 1 patient per day. But if they are on the anesthesia side, a student is expected to know and help with all the cases of their slate. They are expected to interpret appropriate investigations. They should develop a systematic approach of patients in the OR and critical care or critical care. They should demonstrate clinical decision-making skills, prioritizing patients' values. They, under supervision, they should demonstrate appropriate procedure skills. So for this year, we are not expecting that they're going to perform any procedure, but we would like them to have a walkthrough discussion with the staff about the clinical encounters that we're going to talk about. So we are not expecting that they're going to do intubation or central line or bag mask ventilation, but we would like them to at least discuss and have a verbally discussion, walkthrough discussion with the staff. So that's one thing that we'd like to inform the staff and ask them if they have time. They could help the students complete those clinical encounters. As number 6, we have demonstrate. So they need to know Connect Care. They need to know how to document on Connect Care and communicate using that system. Remember, those med students will be R1s in a few months. So they need to know how to use this system, the electronic medical records that we use here. Describe initial airway management, interpret data from non-invasive and invasive monitors. Be familiar with common used drugs in anesthesia and critical care, and develop a systematic approach for shock and respiratory failure, recognizing the different types of shock and the different types of respiratory failure. So for the item number 10, we have the academic half day with cases about shock and respiratory failure. So they are supposed to learn those topics during our AHD. So regarding student allocation, on the anesthesia side, we have 2 students at the U, 2 at the ALEC, 1 at the MIS, 1 at the Grainas, and 1 in Red Deer. On the critical care side, we have 3 students at the general system ICU, 1 in CV ICU, 1 at the Royal ALEC, 1 at the Grainas, MIS, and Sturgeon. I would like to acknowledge and thank all these site leads because Dr. Detillo, Dr. Lam, Needham, Rutan, Eric PG in Red Deer, and all the doctors from ICU, Dr. Lau, AWS, Dr. Robinson, Dr. Odenbach, Davenport, and Nicole, because they are the ones that are responsible for the supervision of the students and make sure they have enough exposure in the OR and in ICU. So one of our main resources is this Med 556 website. If you want to take a look on the website, you can scan the QR code. Here we put together all the information, including learning objectives, anesthesia handbook, critical care handbook, mandatory videos to be watched by the students before the AHD, optional lectures, and many other student learning materials. It's important to say that you need to be logged into a Google account to access this website. So regarding EPAs and clinical encounters, the student is supposed to have 4 EPAs during their 2-week rotation. At least for the critical care side, 2 EPAs should be completed by the staff. On the anesthesia side, the 4 EPAs need to be completed by the staff. The reason for that is that because on the anesthesia side, we are trying to avoid booking the med students with residents or fellows because we'd like to have a one-on-one teaching experience. But on the ICU side, they can request, because they are more like a team in ICU, they can request EPAs from RNs, fellows, residents. Okay. For the timing of EPAs, this is a very important topic. So the duration of the clerkship is just 2 weeks. So if you can complete the EPAs with a student in person at the end of the day, that would be better. Because if it takes too long to complete it, the students are going to rotate and they will not have these EPAs completed within 2 weeks. If you receive a link online, it's because you did not complete in person. I would like to ask you if it's possible, please complete as soon as possible. If you take more than 3 days to complete it, you're going to receive a reminder email from the MD program. On top of that, they also need to have the 3 clinical encounters performed. So the 3 clinical encounters are airway and oxygen management, intubation management, and central line insertion. Why central line insertion and not peripheral IV? So during our curriculum development and discussion, we found that the central line would be, walk-through discussion would be feasible for both sides of the clerkship, anesthesia and ICU. And we also thought at that point that these students will be R1s in a few months. So central line is an expected and desirable skill to have as an R1. Okay, so don't worry about filling any clinical encounter. You are not expected as a staff, you're not expected to fill out as the EPA. So you're not receiving any email for clinical encounters. The only thing that we would like to ask the staff is to help the students to go through that walk-through discussion about the 3 clinical encounters. So they at least need to work on the steps of each of these procedures. So these clinical encounters are mandatory, and the marks for the students will not be released until the patient encounter log is completed. Here is a sample of EPA. So it's kind of similar to the resident EPA. One thing that I would like to highlight here is that you are asked as a staff to think that that med student is a resident in their first year of the residency program. So based on that expectation, you need to see if they are below an R1 level, still developing, or at or above that level as an R1 in their first day of rotation. Here is a sample of like the clinical encounter. So it's just one screenshot of the first encounter, airway and oxygenation management. So again, if you don't have time or if, so those clinical encounters are not, we don't expect the student to do it, but we'd like them to discuss the situation with the staff. So for example, and we highlight this here. So we say to complete this encounter, you must observe, assist your staff or fellow physician with this procedure. If there is no opportunity to physically demonstrate these skills, you may complete this encounter by discussing, verbally walking through the process of airway and oxygen management with your staff or fellow physician, making sure to hit the following objectives. So for this clinical encounter, we expect that the student will learn and discuss about bag mask ventilation technique and the several oxygen delivery therapies that we have. And this is explained in our pre-made videos. We have everything really nicely explained in our lectures, airway lecture and breathing lecture. You're going to talk about the pre-made videos very soon as well. So this is the videos I'm talking about. So I just talked about. So here's the structure of the academic half day. So this will happen on the first Tuesday of the clerkship from 2 to 5 p.m. The students are expected to make the most out of it. We recorded lectures about airway, breathing, and circulation. And also we made a pharmacology sheet. Dr. Sunny Fong, it was amazing with that pharmacology sheet. He helps us a lot. So we expect that the students, they receive instructions that they should watch those lectures and should study that pharmacology sheet before the initiation of the rotation. So then when they come to our academic half day, they are ready for the interactive session that we do. So how this interactive session works. So we have every second Tuesday of the rotation, we have 12 students divided in 3 groups. So 4 students in each group. The facilitators will be given these pre-made slides and the case guides. The cases that we are discussing during our academic half day are trauma, sepsis, and hypoxic respiratory failure. So the dynamics of the HD is like that. We divide the students into the red group. The red group has the case leaders. So these students, actually, they have the cheat sheet, they have the answer keys, and they are the ones prompting the black group. The black group are the case doctors. So they behave as the physicians that are taking care of that patient, the trauma patient, for example. So they are the ones that are basically answering the questions and keeping the discussion going. And also we have the blue group. Those students, those 4 students are the note takers. They are not passive. They are not in a passive situation. They are interacting because they also can help the black group. We decided to do this format because we'd like the students to study the lectures, and we'd like them to conduct the discussion without having that format of us teaching and they just listening. So in this way, we found that they can participate a little bit more. So after the trauma case, for example, is done, these students rotate. So we have 3 cases and we have 3 groups. So all the students have the opportunities to be case leaders, case doctors, and also note takers. The facilitator is there with the case guides. So it means that every session is conducted in the same way. So it's an interactive session because the facilitator is really a facilitator. They are not giving the lecture per se, but they do that in a standardized way because they have the case guides. So here are our mandatory videos again. We have that should be watched by the students before the initiation of the rotation. So A, B, C, airway, breathing, and circulation lectures, and also the orientation to the critical care side and anesthesia side. Here, this is our links, okay? So these slides will be available to you, so you can have access to all the links that we have on the slides deck. On the top of that, on the top of the mandatory lectures, we developed these optional videos. Those ones are, I really would like to say thank you to Dr. Lau and to all the ICU doctors that developed around 17 lectures. And they are about several topics, critical care topics. So it's a really nice resources for those who want to go, to those students who want to go deeper on those topics. On the anesthesia side, we have our website that was developed by anesthesia residents. And we also have very nice lectures. And the students also can have, so all of those lectures are optional, but they are interesting if the students want to have more information about anesthesia topics. Regarding faculty appointments, one thing that we need to emphasize is that the students cannot be booked with staff who do not have an active faculty appointment. So if you do not have a faculty appointment, please contact us. Here are the emails. We can provide you with that. Actually, staffs that do not have faculty appointments, they are not even allowed to work with residents. So that's a nice opportunity to have it done if you still don't have it. So this is the logic model that we are following for the clerkship Med 556. This area is Kelly Gibson's expertise area. If you guys have questions, she's the one that can expand on it. I'll briefly go through it because I find the last column really important for us because that's our ultimate goal. So basically we have the first column, we have everybody that's involved in this clerkship, like students, preceptors, clerkship coordinator, physician rotation leads, everybody, administration, the programs that we use like Kali and SurveyMonkey. So these people perform activities such as scheduling med students, creating welcoming and safe learning environments, providing orientation to med students, creating evaluation forms, in a such way that generates an outcome in short term, mid-term, and long term. So for short term, it goes to increase the knowledge of the med students and hopefully create positive experiences with learners. For midterm, we see that around 2 years, we're going to try to improve the experiences, not of students. The students are in yellow and preceptors are in green, right? So we're going to try to improve the experiences, improve their perceptions about the clerkship over time for students and also for staff. And hopefully, we are going to try to identify new advocates for medical education in our department. And ultimately, for long term, we try to have strong R1s when they become residents. So our goal is to develop well-rounded clerks ready for residency within a few months after the clerkship. So talking about compensation, this is handled through undergrad medical education. It's processed after the end of the 4-week clerkship and applies only to the clerkship students. It does not apply to elective students or residents. If you are a primary preceptor and you have the student, you're gonna have that $40 per day.
Oh, $40 a day.
Another reminder,
Sign me up. Being one of those students.
another reminder. Did he say? Okay. Another reminder is that only faculty appointment staff are eligible to receive remuneration. So that's why it's important to have that faculty appointment that we mentioned in the previous slide. So for the future, we are working on that. So for next year, we are planning to start simulation in airway and vascular access. And this will happen on the second week, the second Tuesday of the rotation. So for the first Tuesday, we have the academic half day. And the second Tuesday, we're trying to have the simulation stations. So for that, we need help. Please let us know if you have interest in helping us, including residents and fellows. Our plan for the year 2027-2028 academic year, we are planning to have a new course. So we are going to have our own clerkship. We are not going to be under the umbrella of internal medicine anymore. How feedback from students work? So basically, the students at the end of their rotation, they go to Cali. That's the system we are using now. And when they give us the feedback, the Cali system generates 2 types of reports. One is the individual teaching report. So you're going to receive an individual teaching report as long as you have completed 3 or more evaluations. The more EPAs you complete, the higher the likelihood of receiving a teaching report at the end of the year. But we also have the clerkship evaluation report. This is more of a summary of an overall feedback for the whole clerkship. And this works for quality improvement and to flag any issues with the learning environment on Med 556. We have already received some preliminary feedback with those weeks of clerkship. So they are anonymous. Apparently, they have had great experience. The students value having this as a learning opportunity, and they appreciate the learning resources that we have developed so far. They found EPAs a bit challenging to be completed. And also, it's not here, but we received an email saying that they found our academic half day too heavy, not enough time to finish the cases. So we are working on that and see if the duration of the academic half day needs to be adjusted. So as teaching resources, we just like to show you that we have this website with these modules for staff that are working with the clerkship. So examples of the modules is teaching in a busy clinical environment is one of them. You can watch it if you want, and if you can claim for category for CME credits. Here we have a few important links. Again, this slide deck is going to be available to you, and then you can go through all those links. Basically, we have the mandatory videos, the optional videos for critical care, the optional videos for anesthesia, the pre-made slides, and the case guides. We also have our website, our handbooks, and a little bit about Kali. That's the new system that we use for educational purposes. Well, so I think the important part here is to open for questions, and we are also very open for suggestions because we are learning as well. We have just started it, and we are open to suggestions to improve what we are doing. Thanks so much. So let's see if there is any question. Dr. Bistritz is saying that you can also see on users.med if you have an active faculty appointment.
On users.med, it'll say eligible to teach, and that means that the university is aware that you have a faculty appointment. So if it says not eligible to teach, then reaching out to your chairs to get that faculty appointment.
Just to follow up on that, our office has been working on that over the past month or so. We have a spreadsheet with all of you on it. The vast majority of people do have active faculty appointments. This was sort of linked to that email CCID fiasco from a month back. When you come on staff, we ask if you apply for a faculty appointment and you facilitate that. So you start out as a clinical lecturer, then get promoted to assistant, associate, etc. So appointments are renewed after a certain number of years. There are a few people at the moment who are kind of between steps that need to get promoted to the next level or stay where they are. But we're working with you at the moment to make sure everybody has an effective appointment.
Does anyone have any questions from Zoom?
Hey, Simone, it's Riley.
Hi, Riley.
Just a one question to start with. You said that they don't have to do things like bag mask ventilation, intubation, IVs, and all that sort of stuff. Like, are they not allowed to, or they don't need to meet their objectives?
We would appreciate if you allow them to do it. Of course, if they can and there is an opportunity for that, please do it. But for this year, it's not expected that. For the next year, because we are doing the simulation station, we will change that word. So instead of saying that they need to do a walkthrough discussion, we're going to say they will perform that procedure. Dr. Lau wants to say something.
Hey guys, so the guidance that we got from the medical schools that we have to treat all the medical students the same. And what ends up happening is between critical care and anesthesia, there's quite a lot of overlap, but there's also things that are unique to each specialty. So within the critical care realm, the medical students probably won't have a lot of opportunity to intubate in line. And on the anesthesia side, maybe lots of opportunities to do intubations and maybe even peripheral IVs, but even at the community sites, they may not have access to doing the central line part, right? But we wanted all of them to at least have the knowledge. There's videos readily available on both sides for them to be able to do that. And the idea is that even when we have them come as residents, which could be as short as 2 months, but even as long as 9 months for this curriculum, and they'll be R1s, the idea is that they still need to know all the steps, because eventually we want them to get, the ultimate goal of this is that we want them to be competent residents. The reason why is because some of the students, or at least some of the schools in the country, have in the past been deemed having their medical students be deficient as they're heading into R1. And the other thing too is that U of A, like many other schools in the country, have code teams that are primarily comprised of R2s from ICU and so on and so forth. But there are schools in the country whereby code teams are actually made up by R1s. You know, if they're rotating on cardiology, they'll do the line part. If they're rotating through ICU, they'll do the airway part. But then sometimes GIMers are also running codes. And I know for sure that's true because I've been at centers where R1s are actually running codes. So that's a bit of a scary kind of prospect. If they haven't even talked through it and don't know the steps, how are they going to actually competently look after people July 1st? Right. So that's kind of the mentality is why we're doing this, giving them a longer runway for them to at least know the steps. And then the plan is for next year, and Simone is one of the biggest proponents of this, and I agree with it, is that we will sim those particular those skill sets at the academic half day in the second Tuesday. And the idea is then not only are they actually being taught these skills, but we're also going to concomitantly evaluate them at the very end of the half day. So such that a lot of the patient encounters will actually be done by the faculty. And, you know, we can also have senior fellows from ICU and as well as, senior residents from anesthesia to help us out with this if they have, interest in education or they have some sort of educational component as part of their residency or fellowship. So that way it alleviates more of the stress on the faculty when you guys are actually caring for patients. There was a comment specifically from the ICU side whereby, the staff might be very busy running codes and things like that, where it's going to be difficult to always do all these evaluations. So we're kind of trying to alleviate some of those by doing them in half day. And then the final thing I would say about the half day as well is that we created some supplementary lectures. There's quite a few on the ICU side about like GI bleeding, massive transfusion, but they are applicable to, both sides. The medical students might be put into their second choice specialty because there's only so many spots in both sites. But what if they're more interested in critical care, but they matched anesthesia, or more they matched anesthesia, but they're more, or vice versa. So the lectures are there for you guys to be able to, even if the afternoon is quiet from the anesthesia side and the students want to have a bit of learning, but you guys are busy with other things like admin or, other teaching responsibilities, there's a way for the students to continue to learn that is asynchronous and not necessarily like, there's not as much pressure on you guys to teach one-on-one. The hope is that you guys still do. The hope is that you guys still expose the students to intubation, talking about airway management and talking about central lines. But there's no expectation for you guys to do that. The students can also do independent learning on their own with the videos. I'll stop there.
Thanks, Vince.
I've been here 35 years, and you're actually wrong at the beginning. This is an incredibly ambitious topic, incredibly ambitious. But over the 35 years, the message that I've received was, oh, they don't need anesthesia. Oh, they must have anesthesia. They can't have anesthesia. We have to do this. So it's just the flavor of the month that comes. And this might be a new flavor of the month from my eyes. And I said, but what I would ask you is it will be very difficult at this site for our, medical students to come in and see some of the complexity that happens. It is way beyond what they can expect. It's just like yesterday, you add up most of the ejection fractions of my patients. I was in level 3, and with 5 patients, you get to 120. And so do they understand that? No, they don't. It's not that they're stupid, they're just ignorant. And there's a lot of stuff you have to get together to be able to do that. I would ask you, how many hours a day would you expect us to have one-on-one teaching in the operating? Because if it's 4 hours, it ain't gonna happen.
Well, we all have been med students at some point. I hope that my staff didn't think I was stupid. We are learning everybody's learning, even me. When I have a case tomorrow, I study the case before I go to that case. I would say that the med student should not be in a room where the ejection fraction of the patient is 20%. So you're trying to put the med students in suitable rooms. That's one point. If that happens, it's our mistake, scheduling. We should not have that med student in that type of room. The second thing I would say is that I don't think we have a time frame that the med students needs to be with you. They are scheduled to be with you at that day, like during that day. I can't tell you, oh, they need to be 4 hours or 6 hours. They are there for learning. So they should be there as much as possible, like for the slate. So our slate finishes at 3:30. So they should be there for the whole day. They're expected to stay with you until the day ends. If you believe that that specific case is not okay for that med student, you can always give me a call. Like if you on the anesthesia side, you can give me a call, or on the ICU side, you can contact Dr. Lau, and we can replace the students. We can remove the students from that room and move to another room. Or if you prefer, you have the access to those resources, the cases. You can always send the students, oh, look, you're going to have the academic half day tomorrow. Why don't you go and read that case, study that case, and be ready for tomorrow, for Tuesday, if you have them on a Monday. And then doing that, you're going to be helping the students because they are studying at that point, and you're going to free yourself. That's one thing that I would say. But ideally, the med student should be in a room where they can have some benefit from that room. Regarding your first comment saying that I was wrong regarding like the history you said. Yeah, so I don't know. I was not here. So that's why I said, look, that topic is good for discussion. I don't know what happened. I don't know if that structure exposure to the clerkship existed, but that's what I heard.
Yeah.
So you are here to correct me.
I give you that information. So around 2014, we sort of fell out of love with each other, the medical students and the anesthesiologists. It was less popular, as you rightly said, than it is at the moment. They weren't particularly interested in it. I think we all know that if we have a med student that's not interested in what we're doing, it can be a frustrating thing for everybody. That has changed. Now there is a real desire. So you're absolutely right.
Can I say something as well?
Yes,
So I'm
Dr.
just going to speak to a couple things. So remember that there was some sort of governing body that deemed that the medical students were deficient in certain things. And to speak to the point about the person who mentioned about the fact that, yeah, like they're coming in potentially underprepared, they might be overwhelmed, they might not necessarily have the skill set to do this. But at the same time, how is that going to change them when they become R1s? They're going to be still deficient, right? So as Simone has already mentioned, all of us are MDs because somebody gave us an opportunity to do this. They taught us along the way, and we're at a teaching academic institution. It doesn't make sense that we have affiliations with all the different community hospitals and the academic centers and that we don't necessarily teach. I don't think that's a necessarily the right thing. The other thing too, that we've heard comments from several faculty is that, oh, if they are deficient in this, like we're going to reduce the exposure to each of these different areas. I think that if they had a case whereby they knew about the EF and things like that, that's a teaching opportunity that they're not going to give the same induction doses for this particular medication, or they have to think about maybe I have to do lines and pressors beforehand. In fact, our academic half-day cases do talk about dose reductions and what other preparation they need to do for a very, very sick patient. So I don't necessarily agree with the fact that, you know, if it's a difficult case, therefore the student shouldn't be there. That might be a time, again, the number of hours in terms of teaching is it's not even set. In fact, there's in our handbooks from both sides, critical care and anesthesia, if the clinical case requires that the staff do more resuscitation than teaching, there's actually no expectation of teaching those days. And even on those days, there is the opportunity for them to learn at the academic cafe. We're trying to alleviate more of the bedside teaching, but we also encourage you guys to do bedside teaching because there might be some nuance and some very special things that you guys can teach that other people can't. So we would still highly encourage you guys to do that. The medical students have been clamoring for this. There's been a lot of feedback already for the first 4 weeks that they're really enjoying the rotations, both from critical care and anesthesia. And it's the fact that you guys are actually being there and actually evaluating them and teaching them. So please continue to do that.
Dr. Flexer?
Yeah, I just also want to provide a counterpoint to the concept that this is a waste of our time. You know, I've also been doing this for 20 or 30 years, and over that time, I've seen our perceived status and our perceived expertise and importance and absolute necessity of the system diminish to the point that I have surgical colleagues who think, why can't I run 4 rooms at a time with ancillary helpers? And I think we've done ourselves a disservice by isolating ourselves from the teaching process. People come out of medical school either not knowing what we do or not valuing what we do. And this is an opportunity for us to explain why you can't give just anyone responsibility for a patient with an EF of 20% and why we bring value to the table. So when we're moving forward in the future, we're going to have our medical colleagues who might not be in anesthesiology or critical care, but at least they'll have the knowledge of what we do. And if we do not step out of the shadows, I think we do ourselves an existential disservice in the long run. So well done. I'm really excited about this coming on. And I'll be honest, there's a flood of emails that always come through my mailbox. And I'm going to go back and reread what you sent us out a couple of weeks ago about the rotation. I'm going to also pass that on to my colleagues because I think this is important and this should succeed for our own benefit, as well as, of course, the students.
Dr. Delane had a comment.
Dr. Delane?
Well, look, I just want to say, I want to thank you, I want to thank Vince, because I actually didn't realize until I saw your presentation this morning, how much work you've done. There's such a huge amount of work. I'm looking forward to seeing those videos. The students are not stupid, they're not ignorant, they're really excited to be here. And I think, I think it needs to be said, this is a pilot year.
Yeah.
I'm hoping it's going to be a success. We work at a university hospital. Everybody on the call this morning works in university hospitals. This is the kind of thing we should be doing. And I think they're going to be very grateful for it. So I want to thank you and everybody else tonight. Thank you.
Nathan?
Yeah, so this consideration is more so, I guess, related a little bit to Dr. Fletcher's comment as well. Just in regards to the kind of advocate for anesthesia as a specialty that's respectable and requiring complex investigations, complex set of skills. I think there's an unfortunate narrative that kind of gets pushed for anesthesia as a lifestyle specialty. I'm going to press the sleep option on the basis of that. Sleep that's it. And it's amongst the public. Well, I focus and unfortunately have that perspective. But even more unfortunate things that's mentioned is some of our colleagues in some different specialties don't know what we do. And I think if all these all of us see as they rotate through are those very simple cases where for them they could run a course, but for senior staff who's that is just a run of the day for them, it is super chill for them. That's what they're going to take away. It's anesthesia seems very simple, easy. Doesn't seem like we do much. And the biggest what you get kind of those applicants applying to our residency programs with that in mind.
Yeah.
Whereas I think for hands-on learning and for skills, I think the majority of those days of those experiences should be in those rooms because they get the actual skills and it's something that's talent and digestible for them. But I think whether it's 1 day in their 2 weeks or 2 days in their 2 weeks, to go into the more complex where they have where they absolutely fill out their time. If they know who it's fun. It's good just because you can see, okay, this is serious. So I don't know, there's a way to work that set that expectation where website will say, you will be intentionally slated single case rooms where you can develop skills and have more opportunity to participate. There will be 1 or 2 days that will place you in stage so that you can see the process. That's the
I don't know if the Zoom people that are on Zoom heard. So Nathan Goldner, our resident, mentioned that other specialties and med students sometimes think that anesthesia is an easy specialty. It's just turn on a button, turn off the button. And so with this exposure, this mindset might change. And then he suggested that it's nice for the students to have these easy rooms because then they can develop these skills. So when I told Richard about, oh, maybe should switch the rooms, I meant by that I would like the students to develop those skills during their rotation. And it's hard to develop those skills when they are in a room that is like a very sick patient, right? So Nathan is mentioning that it would be nice the students who have those easy rooms to develop the skills, but at least once over the 2-week rotation, have the exposure to that difficult case, the ejection fraction that Richard mentioned, ejection fraction of 20%, and then the med student will change their mind. Oh, this specialty is not that easy as I thought. So they deal with complex cases and sick patients. So that's his comment.
Can I make a comment on that?
Yes, of course.
Hi, everyone. Darryl Rolfson. Nice to meet you. So it's not just the respect that needs to be there. It's also you will entice people, not just to choose anesthesia, but we're actually actively trying to create pathways for generalism. And so there'll be people that sort of actually are interested in learning more about it. And so it may be that they don't have a full-time job, as an anesthesiologist or as a what do they call it? GPA,
Mhm.
like GP anesthesiologist. I think there's another term, FMA. I think that's
FPA.
FPA. There we go.
Mhm.
But they at least it may be something that they understand and are drawn towards. So I think there's that. You just don't understand what you don't do. And that old saying about see one, do one, teach one, that this is the C one. And then during their time, then they hopefully get to do one as well. But that's the optional part. And then they come in that much more prepared in residency. So back.
Dr. Dara.
First of all, commenting about the program structure. Walking on either side of the pond, I have never seen such an incredible structured program for medical school. So thank you very much to all of you, all the developers. And I wish I had this kind of program when I was a med student. Echoing what Richard said, some days, at least at the university hospital, many of the days, you will have patients where, like our adrenaline level is probably a bit higher than the other days. And sometimes it is a, like mixed with probably not the best option that day. I want to just get on with the race, probably in a sense that I'll not be able to teach as per their expectation. However, I also think that the scheduler here, which is usually at a senior resident level, it will do an incredible job as well. Which is not possible for them to check all the rooms and check all the patients that, like, we can see that, okay, this patient has a pulmonocytoma, so probably one of the senior anesthesia residents would like to be there in that. So I get that. I think that if the med student also have this in background knowledge or in mind that some of that is just what we said a couple of weeks ago. There's some days I will get more hands-on, some days I'll get one-to-one teaching as a classroom teaching type of thing, and some days I'll just be an observer. I don't know what. Like I think that what Vincent says that this is a deeper involvement that, like they are going to be our one at some days. So they are going to face the situation, although I do not expect first year R1 to come and help me on one of those, the very difficult days. And that will be, I think, unfair for the med student and R1 as well. So that's just my 2 cents. But thank you very much once again.
Yeah.
I really look forward to be an active part of the whole program.
Thanks so much.
And I'll just second that, because I know we're coming to a close here, Vince. I see probably those online can't hear all the comments in the room, but it was a comment of appreciation that I will echo. I mean, this is well structured in a short period of time. I want to thank Derek for your support in planning for this. We've been discussing it, like was said, for at least 2 years. And we didn't rush it, you know. I think it was going to be 23 and then 24 and then 25, right? So it was thoughtful. Vince, I see you got your hand up, but for both you and Simone, thank you very much for stepping up and taking charge and working together in such a unique and innovative way, right? To have these two working together. And I also want to give a shout out to Rebecca Lee, who hasn't really spoken up yet, but Rebecca is the lead for the Med 556. And honestly, you've done a fantastic job working as a team with the other two. So thanks to all of you for preparing this and making it happen.
Dr. Lau?
Yeah, no problem, Darryl. It's a pleasure. And the only last piece, I know we don't have a lot of time, that I'll just speak about. I think having these exposures is very important because it'll actually also, even though we're probably not measuring at this point, I imagine that the students will feel more comfortable when they transition. I wonder if it actually will improve patient care when all the July 1 first R1 start. And I actually think it'll be good for the system overall, because I think that critical care and anesthesia are the best resuscitationists in the hospital. So why would we allow other groups to actually teach those aspects? So I think that we have a responsibility to the students, but I also think we have a responsibility to the public, because they're going to be ultimately looking after our loved ones, our friends, and everything else. So thanks for the opportunity.
Thanks, Dr. Lau. Thank you, everyone.